One thing I liked about coming to HealthSpaces over the past decade or so was a gentleman named Walter Jones who recently passed away, the late great Walter Jones. But Walter, over the last 7 or 8 years, would come up and give a master class really each year on where he was on Metro Health and that project. For any of you who have seen him, it was just always educational and well worth your time. So not to give the impression I'm a Walter Jones, he was a class of one, but in that genre or in that uh, method of how do we think through projects, I'm here today to talk about a project that I'm involved in now over the last 5, 6 months down in Dallas, Texas, with a new pediatric campus that we're building. As part of that, it was announced in February, but for those who are in the Dallas market would know that it was probably the arguably the least kept secret in Dallas, in that they had, it's a joint venture between UT Southwestern, which has a medical school, but also hospitals, and also with the Children's Health. And as part of that, they put together planning about 4 or 5 years ago, developed the planning team, hired the architect, hired a construction manager, and at the end of this year, 2023, they went to the respective boards, meaning the Regents, Board of Regents for the University of Texas and Children's Health Board, and announced this new hospital. So a lot of excitement in Dallas about it. I'm prior military, and I kind of equate it to when people find out I'm military, they always say thank you for your service. So people, when I tell them I'm new to Dallas, they say, what'd you come to Dallas for? So well, I'm here to involved in building the new children's hospital. It's the same type of, oh, thank you for moving down here and doing that. So a lot of great excitement in the community about it. Recently, since the announcement in February, there's been a lot of philanthropy. There's been a $100 million gift that was recently announced. So a lot of excitement in the community. So a little bit about it is it's like we're preaching to the choir a little bit, but the buildings are 60 some years old at the current Children's Dallas. A little bit about Children's Health. It is a 2-hospital system. The main medical campus is in Dallas. 15 years ago, opened up another hospital up in a community called Plano, about 20-30 minutes north of Dallas. That hospital, we're opening a new tower at the end of this year, and that'll basically double in size. But the hospital we're talking about for the replacement campus is the Dallas one. As part of that, they took a look at a couple years ago, as we know we need to grow, as we know we need to upgrade 60-year-old facilities, can we do it in place? And the answer was basically no, it'd be too disruptive. It is a very tight grounds that they're on. And the other reason they're looking at in addition to the age of the facilities and new technology and everything else, Dallas has really taken off over the last 10 years, but interestingly enough, over the next 25 years, the pediatric population is expected to double. So a lot of growth in that area. It will be one of the largest hospitals in the country, children's hospitals, and it's a different model for UT Southwestern and Children's Health in that in the 1960s, the University of Texas granted land for a hospital which Children's Health took to be the pediatric teaching hospital for UT Southwestern. So the hospital actually sits on land that's owned by the state of Texas. This new hospital will be a joint venture between UT Southwestern and Children's Health, and meaning not only will there be the clinical tie-in, but there will also be financial tie-in as well, which they believe, as part of that, when you get everything aligned from clinical, safety, research, academics, financials intertwined, it'll really be the model forward over the next 60 to 80 years as they climb to be one of the top pediatric institutions in the country. And when you look around at other children's hospitals in the United States and what they've done, certainly a lot of beautiful facilities. And one of the things that's really top of mind is as we're going out and trying to get these young students that come in to go to medical school, that this will be a facility they'll want to practice and come and learn and hopefully stay in. So the hospital itself it's not really going to gain a lot of extra square footage, but as you see the different things it will have, it'll be much more efficient square footage than it has now. It'll grow 152 beds. It has the capacity to go up to about 800 beds, be doubling the size of the NICU. And I heard this morning in the first session, they talked about, it's amazing how many conversations you have about toilets in hospital. I'd say number 2 is parking. So as part of that, we're basically doing about 50% extra parking on the campus. We are building outpatient services there as well. We'll keep our specialty center, they call it, in Dallas on its existing campuses, but your high acuity services, your oncology, your cardiovascular, a lot of those types that it makes sense to have one-stop shop on the campus with the inpatient and outpatient. We'll be moving out there, and then we'll repurpose some of that space that they move out of. It is moving about a mile down the road from where we currently are on land owned by UT Southwestern. One of the unique features we'll be able to do is tie a sky bridge, which we'll show you in here in a minute, between both hospitals. So if you have babies born in labor and delivery at UT Southwestern or Clemens Hospital, they will be able to be transported inside the building through a sky bridge over to our NICU or cardiovascular ICU. That's a rendering of the campus. If you look on what's your left-hand side, that is starting in that left-hand side, that's the Clemens University Hospital. The road there, you see a sky bridge going across to the 3 patient towers. That's Harry Hines Boulevard, a pretty active, highly trafficked road in Dallas. You'll see the 3 towers. Behind it, you have emergency department on the left-hand side, a big diagnostic therapy in between, and you'll have the outpatient building on the other side. You'll see a sky bridge continue over toward the right-hand side, going to a employee parking, and behind that employee parking is a thermal energy plant and microgrid. So pretty big campus. My position is a new position. I was recruited last summer, went through the process, onboarded in October. So as part of that, I had to come in. We are finishing up the planning and getting into where we're moving into execution of the project. So as part of that coming in my experiences, I have over the last couple months given it my little twist that come from projects I've been involved in. I'll talk about that a little bit, and just to go back, of how I think through things. In the U.S. today, there's $80 billion worth of construction per year. And the last 2 decades, if you do any research on healthcare construction projects, it's been consistent, depending on which studies you want to tend to believe, but somewhere between 27 to 37% of projects have significant issues with either schedule, budget, and usually it's both. And when you look at that, why are we having this continued issues? Because in the U.S., you have top construction management firms, you have the best trades folks in the world, you got great architectural firms, you have owners that are getting more savvy as time goes on of delivering these, yet we're still having those issues. In my experience, it comes down to not that we don't have project management processes and information systems and all the tools to manage that, but they're just complex, and it's that complexity, it's those things you can't map out over the years in a linear process, that are things that aren't really taught through or discussed amongst project teams that we've had some success doing that. So a little bit about my background. These are facilities construction projects I was involved with in the Middle East. The upper left one, that's in Doha, Qatar, Sidra Medical Center. The building was designed by Cesar Pelé, a world famous architect that's passed away. Just a little bit of the complexity of that. That was in Qatar, their healthcare system, the operator and the regulator was all government system, one organization. This was owned by Qatar Foundation, which was a quasi-governmental agency that was set up to develop what is called Education City. Education City had campuses of the U.S. that they built over there and opened. Georgetown University, Texas A&M, Virginia Commonwealth, and another one was Cornell Medical School out of New York, opened a medical school there. So this was going to be a hospital managed by Cutter Foundation. That was going to be the teaching hospital for Weill Cornell. As part of that, they had not procured to that level. This today would be, with inflation, a $5 billion project. Cutter Foundation had not had that type of procurement in their portfolio, so they used Cutter Petroleum to do the contracting of that. They contracted with a Spanish contractor who did large healthcare projects in Europe, partnered them with a Egyptian contractor on a joint venture who did Middle East projects. They had multiple architect firms, engineering firms out of the UK. They wanted it designed to Joint Commission standards, not Joint Commission International, but Joint Commission. So NFPA standards. And by the way, there was no current hospital, so they had to put a project team together, and they had people from all over the world. Well, Western world anyway, US, Canada, UK, South Africa, Australia, who were put together to be that quasi team. So as part of that, it gets very complex. So in addition, you have cultural issues, you have language barriers, all that. You had people who have very good engineers that could do the project management tasks, but it wasn't set up to have a collaborative type of, nobody knew what others were doing. So as part of that, it's like, how do you teach those skills that we can all get on, where it's a no blame culture, where you want to learn what things are going on, that not have the mindset that if you stick your neck out, it's going to get chopped off, so that we can start, making sure we're keeping this project on board. So I happened to be finishing a doctorate program, and that was top of mind for me when I was looking at what I wanted to do for my research. And I was looking at it wasn't the technical or hard skills, engineering skills of managing a project. It was really leadership skills. So what soft skills are out there that can help us as you're managing projects really take a, maybe different type of education that you can provide people and culture that you can instill. And it couldn't be soft skills that were just so broad that it could be applicable to anywhere, but not so tight either, where it only applied to the one project. I came across high reliability. Initially, I knew high reliability through hospitals, and it was associated with safety, patient safety of not having major events. And as I started looking at that and taking a more pragmatic view, I said, really, a lot of these things apply to managing projects as well, because what you're really doing is trying to prevent errors and think about things before they become major issues. So as I started looking through these, I put together a whole research paper. I'm not going to go through this, but if you go to my LinkedIn page, you can find it. I got a copy of the doctoral thesis. But I think it's important to, before I tell you how I'm applying this to Dallas, to really go through a little bit of how I view high reliability tied to construction projects. As you look through the research of Wick and Sutcliffe, they were a little bit late to the game of high reliability research. The prior researchers really looked at how organizations were set up differently than maybe normal organizations. Your aircraft carriers, how they can land aircraft in very harsh conditions, yet have a very high safety record where any error would be catastrophic. Air traffic controllers, nuclear power plants, stuff like that. Wick and Sutcliffe came a little bit differently. Instead of looking how they were set up operationally, they looked at what are they doing that's similar to but different than other organizations. And they came up with these 5 different areas I'll go through very quickly. But these 5 areas really started making sense to me. I'm like, do I really need to, as part of these projects, teach 5 additional things? Will that be of any benefit to the team? When I started thinking through what's the opposite of what they're proposing, somewhere on that spectrum of what they're saying and what the opposite spectrum is we're doing anyway. So once that clicked in my brain, I said, okay, this could really be a benefit. And so that's what we want. So preoccupation with failure is what they're saying. When I put that against the projects I was working with at the time in the Middle East, a lot of them were preoccupied. What's the opposite with success? They want to, find data that will support where the plans were, because nobody wants to be the one bearer of bad news. So nobody was out there looking for mistakes. So it was really teaching them about You know, we need to be open. You need to have a no blame culture. You need to be open to skeptics. You have to be free to bring these things together. You know, we're all one team, and how do we uh, make sure that we're bringing these issues up to the forefront before they become issues. Reluctance to simplify. In projects, you simplify things right down to the work breakdown package. And what they're saying is, you know, you need to step back sometimes and take a look at the picture versus trying to simplify everything to its core. And I heard that a little bit this morning. I think it was Andy. He was asked a question about infrastructure and how he looks at equipment replacement. He said, I don't look at the piece of equipment, I look at the system. And this is what that's really saying is when you are out on the field, particularly when you have some experience, you think you're seeing something based on your past experiences, but until you step back, you may or may not be what you assumed it to be. Sensitivity operations. The other way is sensitivity to planning and really trying to show that your plans are aware. One of the keys for me in the Middle East, sorry, when I was in Abu Dhabi, I was working for one of hospital of a 12 hospital system. The CEO was an Emirati physician. It was a 400-bed hospital building a 700-bed replacement hospital. About 15 months in, he became the CEO of the 12 hospital system. There was 3 other hospitals being built at the same time that were further along in the stage. One of them in the western region of Abu Dhabi. Abu Dhabi is both the name of a city, but it's also the name of an emirate. There's 7 emirates in United Arab Emirates. An emirate's like a state equivalent. The western region of Abu Dhabi is very Bedouin, you went through sand dunes and gas refineries to go for hours driving before you came into these small villages. Dr. Mater called me down to his office in Abu Dhabi as the CEO of the whole system. He had the CEO who was also an Emirati for the western region. He said, I want Bob to go out and see what's going on with your projects because we have these delays. We want to see, have him help come in and see what we can do to get this open. So we made an agreement. I drove 4 hours out. I get into a room, and again, it's not a lot of Western professionals out in the Western region. I get there, there's 25 Arab-speaking individuals in the room and me. Most of them Emiratis, a few other Arab nationals from other countries. And they go into the 2-hour meeting and they speak Arabic the whole time. So the one thing to know about in the UAE, a lot of business is done in English because they bring in people from all over the world. So if you're eating at restaurants and all that, things are, so I didn't know if it was purposeful or not. So I sat there. Well, one of the benefits you have when you're over there, you learn over time that because they speak English, they will interject English words sometimes because it's easier or they don't have an Arabic equivalent, whatever the reason. I had been pre-briefed on a couple of the issues before I went out there. So at one point I just stopped as they were talking about one issue and interjected an opinion and had all 25 of them just kind of stare at me. And I thought, well, I'm just going to give you a little tweak to let you know I'm here. But on top of that, the meeting went on and you could tell they were thinking, does he know Arabic? Has he been listening to us the whole time? Which I didn't. But I left and I had 2 choices. I could call Dr. Mater and say, hey, this isn't going to work. I know you wanted me to get involved, but this isn't going to work. And I didn't want to do that to him. I didn't have that relationship. I was more, try to fix it for him. So what likely would have happened is he would have called and told the CEO, what are you doing? I sent Bob out there. Instead of doing that, I went home, told my wife, I said, I'm not going to be able to do this, just coming back and forth once every 2 weeks. So packed my bag, went back, and just started building relationships. I went to the CEO, said, I'm going to start talking to people. Who do you want me to talk to? Made my way around the circuit. You pick up a little bit everyone you talk to. And I finally got probably a little bit of luck. I got to one individual after I picked up some things. It was almost like a confessional at some point where he just deluged everything on me that was going wrong. Well, again, over there, people were worried about being blamed if you were the one bringing up issues. So I was really able then to take what he gave me, show trust in that I didn't tell people that he was the one who told me that. And I was able then to go around and have other conversations. So at the end of the next 2 weeks came up, I was the bearer of the bad news, in a no blame type way. I was able to bring those issues out, and then we were able to work as a team and to confront them. Commitment to resilience is another one. This really came to light in Cincinnati for me in 2020 when the pandemic hit and our supply chain issues. We were able to really work toward getting the right teams together where we're able to it wasn't really on the owner, it wasn't really on the contractor, it wasn't on the designer to look at who was responsible for the supply chain issues. So we're able to get the right people together quickly and be able to do that. So I just want to say real quick how we're going to do this toward the project team in Dallas. So we got 2 owners. We got a UT Southwestern, which is an academic medical center, and Children's Health was a children's, nonprofit. We got 2 national design firms that haven't worked together, partnered. We got McCarthy and Vaughn on a contractor side. We got all these numerous consultants. So we're able to get together and say, instead of looking at each other as multiple organizations working on one project, how do we view ourselves as we're one project organization? So we're a $5 billion organization that has to set together its own shared values, services. So we went together and we looked at, here's the things we need to look at that we're not going to do as a project. Here's some best practices that we are going to put together. No blame culture, project vision, shared values, shared goals. We went together, we developed our own shared purposes, we put together values using words that children would use, that we are now putting this together, and we're putting it together in an onboarding package where all the teams that we're now getting in the execution phase will have the culture and the type of expectations that we're looking at building as we're moving forward in building this new hospital. So thank you very much.